Recording. Thank you again for joining us at the California Dialogue on Cancer's CDOC Cancer Surveillance Data Webinar Series. So this is the last webinar for this fiscal year ending in June, but the planning for the next year is ongoing. My name is Sheila Senyo, her Strategic Alignment Specialist for the Comp Cancer Program and the California Cancer Registry. Again, please feel free to introduce yourself in the chat with your name, pronouns, and organizations, and where you are joining from. I'll go over some housekeeping while everyone is typing in your intros. So all participants have been muted, but we will leave the chat open for any questions. We'll also have an allotted Q&A after speaker's presentation. So please stay until the end of the presentation to participate in a short webinar evaluation. Next slide. Again, for those who are just joining in, please type in the chat your name, pronouns, organization, and where you're joining from. The California's Comprehensive Cancer Control Program is a CDC-funded program that provides leadership and coordination of statewide comprehensive cancer control efforts. The Comp Cancer Program leads the Cancer Control Coalition, which is CDOC, and it's also required to develop and implement a state cancer plan. So currently, we're still implementing strategies from our current 2021-2025 state plan, but we are in the process of revising the next iteration of a 10-year plan. Next slide. As a background information, these are the current cancer plan topic areas, and CDOC works closely with the Cancer Registry and other partners to implement strategies from the surveillance topic areas you see on your screen. The Comp Cancer Program collaborates with the California Cancer Registries on various surveillance goals. This second objective directly supports the work we're presenting today. Our goal is to enhance cancer surveillance systems so we can produce and share data in ways that are meaningful and accessible to public health organizations, researchers, and other partners. In today's webinar, a CCR researcher will present finding from a quantitative economic of the Cancer Registry, estimating the average cost per cancer case. This webinar illustrates how these data reports can inform decision-making, resource allocation, and cross-center collaboration. By improving how we report and communicate this data, we also help ensure it supports broader population health efforts and meets the needs of multiple audiences. Today's presenter, Terence Kelley, is a research scientist dedicated to advancing epidemiology and public health in the state of California. Terence is a Ph.D. candidate in health services, specializing in public health policy and economics, and has a Master of Science in Health Administration. Terence's expertise is complemented by certifications in health analytics and epidemiology. His research focuses on understanding the complex impacts of chronic diseases, including cancer, tobacco-related illnesses, and neurological conditions on communities. Please welcome Terence Kelley.
Hi, everyone. Thanks for the introduction, Sheila. As Sheila said, I'm Terence Kelley. I'm a research scientist at CDPH in the Chronic Disease Surveillance and Research Branch, which houses the California Cancer Registry. I've been with the registry for about 2.5 years and CDPH for roughly 12 years. And this work was conducted in partnership with Dr. Mark Damison, Dr. Katrina Taylor, and Sandy Kwong within the Chronic Disease Surveillance and Research Branch. And so today I'll be sharing findings from a recent economic evaluation. This work recently presented as a poster at the 2025 NACER conference in Hartford. And let me walk you through what we shared so you can advance to the next slide. So this is the poster I presented at the NACER conference. And for those that are not familiar with the term, NACER stands for the North American Association of Central Cancer Registries. And this poster really provides a high-level summary of our economic valuation of the California Cancer Registry, where we applied Monte Carlo simulations to estimate the average cost per reported cancer case. The analysis was grounded in real-world financial data and explored how the cost per case varies under different funding levels and case volumes. And so these are key factors affecting statewide cancer surveillance. Our overall arching goal was to better understand what it takes to operate a population-based cancer registry at scale and to identify the cost drivers that matter most for long-term planning and resource allocation. Following slides, I'll walk you through our methods, I'll share the key findings, and discuss what they mean for the future of cancer surveillance and public health. And you can advance to the next slide. So to begin, I want to ground us with some key cancer statistics. And so each year, nearly 194,000 new cases are diagnosed in California. This is the highest absolute number of any state in the nation. And while advances in screening and treatment have improved outcomes, there's persistent disparities, particularly among underserved Hispanic and Asian populations. And these disparities are driven by various structural factors, including unequal access to care, socioeconomic challenges, and barriers in navigating complex health systems in California. And so high quality cancer surveillance is foundational for identifying trends, informing policy, and developing equitable interventions that reach vulnerable populations while managing escalating costs. And the CCR, established in 1988, stands as one of the nation's most comprehensive statewide cancer surveillance systems. And given California's scale and diversity, ensuring the sustainability of the CCR is critical. However, despite its recognized public health importance, there is a lack of up-to-date replicable data on what it costs to operate the registry at this magnitude. So this study addresses that gap by estimating the cost per case, per cancer case, for CCR operations and identifying the key operational drivers that shape long-term sustainability and efficiency. And so to put things in perspective, California reports more new cancer cases each year than the entire population of cities like Salt Lake City. And behind every one of those cases is a patient, it's a family, and a story. It underscores just how important it is to understand not just the burden, but the cost and sustainability of tracking cancer at this scale. And please advance to the next slide. So this study addresses a critical gap in cancer surveillance. I mentioned this before, the absence of up-to-date, transparent, and replicable estimates of the cost of operating a population-based cancer registry statewide. And using CCR as a case study, we applied a Monte Carlo simulation framework to estimate the average cost per case while accounting for real-world variability in funding, workload, and operations. The analysis spans multiple fiscal years and aims to produce accurate and actionable insights for policymakers and public health planners. And our analysis focused on 4 main objectives, each addressing a different piece of the sustainability question. So first one, to estimate the average cost per analytic per case reported to the CCR, to assess operational efficiency across the registry's core and enhanced functions, to model how changes in case volume or funding levels impact cost dynamics, and to develop a scalable economic framework that other NPCR and SEER-funded registries can replicate. Our goal is to support informed decision-making by helping stakeholders evaluate the financial sustainability of cancer surveillance, really under evolving public health conditions. And please navigate to the next slide. So we conducted a mixed method economic evaluation that combines retrospective cost analysis with forward-looking simulation modeling to estimate the cost per cancer case. And so the retrospective component involved a detailed review of the CCR's expenditures from fiscal year 2021 through 2024, using actual budget and cost data from both central and regional levels. We applied a Monte Carlo simulation framework to model uncertainty and explore how costs might fluctuate under different real-world conditions. And this method is well suited for capturing variability in key drivers like staffing, case volume, and funding levels. And our simulation ran 10,000 iterations, producing a probability distribution of cost estimates that reflect a wide range of plausible outcomes rather than a single point of value. We also conducted a sensitivity analysis to assess how changes in critical inputs, such as a 10% increase or decrease in funding or case volume, impacted cost dynamics. And so this approach allows us to move beyond static estimates and incorporate risk of variability and real fiscal context into our planning model. And I think this is an essential feature for decision-making in resource-constrained environments. Great. So what is a money calculation and why use it? It helps answer the question, how much could the cost per case realistically vary? And it shows not only the average, but the also best case and worst case and most likely outcomes. So useful for planning, budgeting, and understanding risk. So if the cost per case averages $124, a Monte Carlo simulation might show that most values fall between $118 and $130 per case, and outliers as low as $112 or as high as $135. And so this gives us confidence that our cost estimate is stable and predictable. You can advance the next slide. And so we collected and organized cost data using a customized version of the CDC's National Program and Cancer Registry's Cost Assessment Tool, or CAT. It's an Excel-based tool designed to capture cancer registry expenditures. And expenditures were grouped into three primary categories: so personnel, infrastructure, and administrative overhead. We further classified costs by activity type, so core costs reflected the essential required functions of registry operations, such as data collection and case consolidation, while enhanced costs covered value-added activities like follow-up activities, special linkages, and data quality initiatives. Personnel costs, including salaries, benefits, and indirect charges, accounted for more than 50% of total expenditures and are the largest cost driver. And we also documented funding sources across three main funding streams, such as California State General Funds, NPCR funds, and federal support from NCI's SEER program. And so this triangulated approach ensured full transparency in how public funds were allocated to track or trace spending back to functional registry components. And so to assess cost variability under real-world conditions, I used a Monte Carlo simulation in SAS 9.4. This generated 10,000 randomized scenarios. Each scenario drew values from probability distributions informed by actual CCR expenditure data. And rather than producing a single cost estimate, this approach allowed us to model a range of possible outcomes, accounting for uncertainty in key factors like funding level, staffing, and case volumes. So think of it as a rolling the dice thousands of times to explore typical and extreme cost scenarios. And so the simulation yielded an average cost per cancer case of $124.04, with a standard deviation of $3.12 and a tight spread that indicates strong cost predictability, even under varying conditions. And so the resulting distribution ranged from 112 to 135 and closely followed a normal distribution. We validated this shape using three standard statistical tests. This is through the Kolmogorov, Smirnov, Kramer, von Mises, and Anderson-Darling, which all returned p-values above 0.85, confirming the statistical normality. And so these findings support the conclusion that CCR's cost structure is efficient and remarkably stable, even amid operational and fiscal uncertainties. And you can advance to the next slide. And so here's the distribution of the simulated cost per case with key intervals. If you look at the blue line, that is the mean cost of 124. The green dashed lines, that's showing our 95% confidence interval for the mean, 123.98 to 124.10, and then the orange dashed lines are showing 95% prediction interval for individual cases. And so this visual shows the tight clustering around the mean, reflecting, I would say, high predictability in the cost estimate. And advance to the next slide. And so we also conducted a sensitivity analysis alongside the Monte Carlo simulation to estimate how total funding and case volume variations influence the cost per case. So a sensitivity analysis is really a way to test how much our results might change if key assumptions or input shift. So in this case, we looked at what would happen if funding or case volume increased or decreased by 10%. So a 10% increase in total funding reduced the cost per case to 112, while a 10% decrease raised it to 137. So this is demonstrating a strong relationship between funding levels and cost efficiency. Similarly, increasing the number of cases by 10% lower the cost per case to 113 as fixed costs, such as staffing and IT infrastructure, are amortized over more cases. However, a higher case volume could overburden staff without additional resources, such as slower processing or decreased data quality. So conversely, reducing case volume by 10% raised cost to 137, but may free up time for enhanced quality improvement efforts. So these findings reflect sort of the real world dynamics of a complex system like CCR, where maintaining a balance between cost efficiency, funding stability, and workforce capacity is really essential for sustainable operations. And so the results affirm the efficiency of high volume registries like the CCR compared to some other smaller jurisdictions with costs that exceed 7,000 per case. CCR's cost structure is lean and highly optimized, despite managing the largest case volume in the country. The advantage comes from scale, advanced infrastructure and integration into national programs like SEER. And so therefore, we should review the CCR funding not as really an overhead expense, but as a long-term investment in cancer surveillance, prevention, and control. And the economic modeling approach used in this study, I believe, is very broadly adaptable. So other state-based cancer registries or immunization, newborn screening, or public health surveillance programs could apply similar Monte Carlo methods. This approach aligns really well with calls from researchers like Bayo and David for probabilistic sensitivity analysis and public health economics. And so really, I think embedding these tools into planning processes enhances accountability and operational efficiency. And so, of course, like any model, ours has limitations. It assumes relative stability and doesn't account for sudden disruptions such as pandemics or abrupt funding changes. While Monte Carlo simulations are powerful, they do have limitations. And it assumes parameter stability and cannot fully model structural shocks, again, such as a pandemic. So future efforts could incorporate dynamic systems modeling and longitudinal data to project registry costs over longer time horizons. And so this would really allow for a richer projection of registry performance. And you can advance to the next slide. And while this analysis provides a strong foundation, we're also looking ahead to how we can build on this work and deepen its value through publishing a peer-reviewed study. And we're also interested in applying dynamic system modeling. So unlike a static approach, this would let us simulate how cost behavior evolves, especially under policy changes or sudden funding shifts. And this helps us test not just what's likely, but also what's possible. We're also exploring Bayesian modeling, which allows us to formally include expert knowledge or prior data and update our estimates as new information becomes available. And I think this would enhance the model's adaptability and relevance in dynamic environments. And we're also considering bootstrapping methods where we would resample the existing data to generate empirical confidence intervals. And this is really useful when we want to avoid these kind of strict distributional assumptions and provides a more flexible way to express uncertainty. And so I think these advanced techniques can make our cost modeling more responsive, scalable, and generalizable, especially for a broader public health economic planning. And you can advance to the next slide. In conclusion, I'd say CCR's cost per case is low, it's stable, and it's scalable. Its operational efficiency is rooted in its volume, infrastructure, and skilled workforce. These findings position CCR really as a benchmark for other registries and support the case for sustained investment in surveillance infrastructure. And ultimately, accurate cost estimation informs better budget strength and cancer control across the population. And so thank you for your time, and I welcome any questions or feedback. If you'd like to follow up or explore collaboration, please contact me at the contact information on the slide.
Thank you so much, Terence, for that informative presentation. We really appreciate your time and insights. Let's now open the floor for any questions and comments. Feel free to use the raise hand option or type in any comments or questions, or feel free to unmute yourself. Go ahead, Karen.
Hi, thank you for that informative presentation. I was just curious if you could comment about recurrence rates and our ability to track those, because I think they are a very good indicator about quality of care in terms of comparing across systems and hospitals. And my understanding that there isn't really a uniform way that is tracked. Is that correct?
So I would say one important limitation in most population-based cancer registries, including CCR, is that I don't think we collect a lot on cancer reoccurrence. So unlike initial diagnosis, which is reportable by law and well documented through pathology reports and hospital records, reoccurrence events are often managed in outpatient settings. And so they lack sort of that standardized reportable trigger. But, I think this reoccurrence data, is really not routinely captured in a lot of registry data sets, which can limit our ability to directly analyze long-term outcomes. And so that said, I think, public health programs have developed some workarounds, and we're looking into things like, claims and EHRs and modeling approaches to infer reoccurrence indirectly. But based on patterns of treatment and imaging or new rounds of chemotherapy after treatment, I guess you would say free interval. But I think there could be, improved interoperability with clinical data systems and the integration of longitudinal patient records that could enable more consistent tracking of reoccurrence and other survivorship outcomes. So I think there is a challenge there, especially as cancer care kind of continues to shift into community and outpatient settings. So I did not have a real chance to look at reoccurrence data.
Yeah, it just seems like a really big gap. I know of a case of somebody, for example, who received care at a hospital, which they were not given the correct treatment. As a result, their cancer recurred. Of course, they didn't return to that same hospital and ended up going to NIH. And then, shortly thereafter, passed away, but it's something that isn't tracked. And my concern is that when we don't track that kind of thing, we really don't, there's some quality of care measures that are very important that are missed.
Right, and I agree with that. And I think there is some in terms of, the follow-up process, but that, reoccurrence specifically, with population-based cancer registries, they do routinely track like the vital stats follow-up. And so there is that vital stats portion of it and the cause of death. And this, I think, helps, support that analysis of overall survival. And in some cases, that sort of cause-specific survival. But, recurrence and meaning, really meaning the return of cancer after initial treatment, I say is really not a systematically collected in standard registry operations. And, that's something that I definitely think is, something to look at in the future.
Thank you, Karen, for that question. Any other comments? Li Hua had a question on the chat. Thanks for sharing the great work analysis, Terence. I'm curious about what were included as enhanced activities versus core activities.
Oh, sorry. Can you repeat that? I just lost.
No worries. The question was, curious about what were included as enhanced activities versus core activities.
So for enhanced, I would say these are, in the context of registry, cancer registry operations, and especially when we categorize them in tools like CDC's PCR cost assessment tool, activities are generally grouped into this core and enhanced functions. So core activities are the essential mandated functions required for cancer surveillance and registry compliance. They are typically uniform across registries and, funded primarily by NPCR or SEER. And so this is like case ascertainment, data abstraction and coding, data consolidation, quality assurance. I think the, follow-up, for vital stats and data loss, last contact, but sometimes even follow-up. A lot of times, those kind of costs can also be in kind in terms of the amount of work that's involved. But in terms of enhanced, that goes beyond the basic surveillance mandate. And so that could be those special studies, the data linkages, the geocoding and spatial analysis, support for external research or public data requests. This goes into that expanded follow-up beyond the vital stats, and, community outreach, education, that kind of thing. So those are really kind of the big differences, in the advanced versus or enhanced versus the core functions.
Thank you, Terence. Any other questions or comments? And Terence, we received a few thank yous for your work and analysis on this presentation. All right.
Thank you, everyone.
Thank you. All right, I don't see any other questions. So to wrap it up, please take a moment to complete a short webinar evaluation, which my colleague Joyce have shared on the chat. As I mentioned earlier, this is the last webinar for this fiscal year, but we will start planning for future surveillance data webinars. So if you have any topics you'd like presented, feel free to write it in the evaluation form that was dropped on the chat. Any recording and the slide deck will be shared with you via email. And again, thank you all so much for joining us today and have a wonderful rest of your week.
Thanks, everyone.